Welcome to episode 4 of Community Health Worker Data Dialogues, the podcast where we dive into how data is transforming community health worker programs around the world. I'm Dr. James O'Donovan, Director of Research at Community Health Impact Coalition, and I'm joined by my co-host Dickson and Seema Mbewe, a community health worker from Malawi. In this episode, we're going to be speaking with Hamid Abdullah from Khushi Baby and Mallika Raghavan from Last Mile Health to explore data quality. But before we get into that conversation, let's start by hearing from Deborah and Renata, community health workers from Kenya and Brazil, about challenges they face in collecting good quality data.
Yeah, there's always a lot of pressure when we are collecting data because there is a percentage we are given every month that you have to complete.
Yeah.
So you have to race with this indicator. You must reach your indicator at the right time. By the time the month has ended, you must complete your data collection. And maybe in that month you were sick, or maybe your child was sick, or maybe you had a funeral. It doesn't matter. You have to collect your data despite what had happened.
Existem alguns desafios, né?
Because families, especially the most vulnerable ones, sometimes you don't have everyone at home. So it's difficult to collect quality data. Sometimes you need to go back to the house more than once. Challenges also happen when a person is ashamed of their living conditions, when they suffer some kind of abuse and want to hide it, when they are drug users and don't want to talk about it. You know, not always, when we are collecting data, do they give the correct information. But as we keep visiting these families, interacting, becoming part of their lives, gaining trust, I think that's really important, gaining their trust, right? Because without trust, there's no listening.
Now that we've heard these reflections from the community health workers, let's go to the studio and hear from Hamid and Mallika.
Yeah, thank you very much, James and Dickson. So I'm very excited for this conversation. My name is Hamid. I am working with the community health worker in India since last 10 years. So I started my career with the community health worker, and my role is to train them on the digital health application and also do their capacity building.
Yeah, thanks so much. Hi, I'm Mallika. I'm our Deputy Chief Program Officer at Last Mile Health. I started my career about 20 years ago, actually in New York, in my own backyard, working in different areas around New York City to do like linkage to care for HIV positive adolescents and at-risk youth. So a lot of my work at the time was around how do we connect young people to access services, both at the kind of like primary healthcare facility in the hospital, but also within the community. I then jumped overseas and partnered with the government of South Sudan on their guinea worm eradication program. And that really served a very remote and rural population, trying to hunt down guinea worm in some of the hardest to reach places through a community network, a set of community health workers who are serving their communities, trying to find neglected tropical diseases, not an easy thing. And that really got me excited about the power of community health workers, what they could do, what they could achieve, the way they engaged in their communities, and just the trust and the engagement that they were able to build. And I was really lucky to be able to join Last Mile Health about 10 years ago in Liberia, where we were founded during the Ebola epidemic. And I think that's really where we saw the power of community health workers to prevent, detect, respond to Ebola. And from there, I partnered with the Ministry of Health to actually design and implement and scale the first National Community Health Assistant Program in Liberia. I think drawing on a lot of lessons from other countries who have been successful, India included in that. So really excited to talk more about ASHAs and the Anganwadis and many of the other health workforce, I think in India, that have inspired a lot of other community health workers around the world. Over the last 10 years or so, we've designed and scaled the Community Health Assistant Program in Liberia. I've been lucky to have been able to then help start our work in Malawi. So Dickson, excited to speak more about Malawi as well, where I know you serve, and partner with the ministry there to really strengthen the community health workforce. And I also now oversee our programs in Ethiopia and Sierra Leone. So I've been really grateful to have been able to be with Last Mile Health now for 10 years. And I think just for those who don't know, Last Mile Health was founded in Liberia. Our goal is to ensure that there is a community health worker for everyone, especially in remote and rural areas. And we just believe that no patient should be out of reach from critical health services.
That's fantastic. That's fantastic. And really excited to speak more about the great work you're doing at Last Mile Health and Khushi Baby, especially in relation to data quality, but fascinating background, Mallika, and thanks so much for being with us today. Dickson, I know you have some questions.
Yeah. Thank you so much. That's very, very good explanations from our guests. You are doing really a good job in the respective areas. So the first question to you, maybe, would you explain to us what it means by the word data quality, and also what is it's important for your work, as well? I've already explained area. I'll start with you, maybe Hamida.
Yeah. So the data quality is the data which we can trust or which we can take action, which is reliable. If the data quality is not good, then the resources which we allocate for any program will be waste. So it's very important that data quality should be good. So like as I was telling that we are working now with the 75,000 health worker, we have collected almost 50 million beneficiaries data. And we are also collecting health status of those beneficiaries. So if ASHA and ANM is not selecting the right variable in the application while she is collecting the data, so that data will be no use if the quality of the data is not good. So like as I mentioned that we are collecting these health status, and because the data quality is good, we are using these data in different programs. So like at the time of digital health survey, they are collecting the health status, and if the beneficiary have any disease, she can select that disease from the list, and we are using that data in other different programs.
And can I just ask, Hamid, do you know how the CHWs are collecting the data? I assume they're collecting them on a mobile phone.
Now they are collecting it in a mobile phone. So the main challenge in India in the public health sector is the real denominator. So they do not, for every program they should have a denominator, but it's a very big challenge. So what we did in the application, we created a module which we call digital health survey. So in the first thing which ASHA or ANM have to do is she have to do the digital health census of their village, and that digital health census will be the real denominator for every program for this community health worker. And these digital health survey data can be used in different modules. So it will, if I am collecting the data in the DHS module, it will be visible in family planning or maternal child health, or also in NCD, and they just need to enter the basic information of the beneficiary with the health status. So I think this is what I want to add here.
Okay, Mallika, what about yourself?
I really agree with that. I think what resonated with me is that data quality is data you can trust, data that's reliable, data that you can stand behind and kind of meaningfully say, like, this is the evidence, this is what we believe in. I think good data means that you can use that to improve program quality. You can use it to make good decisions, whether that's decisions on how to allocate finances, decisions on what services to provide, decisions on what's working, what's not working well. That all comes from being able to have the data at your fingertips. So for me, that's a big part of what drives us at Last Mile Health to think about data quality. And I'm excited to share a little bit about our work in Sierra Leone, where we partnered with the Ministry of Health and Exemplars and Global Health to actually evaluate the implementation of the national CHW program across 16 districts. And I know we'll go a bit into actually, like, how do you assure and how do you actually track data quality. But I think one of the things that we felt really excited about was having good data, having quality data meant we could look at kind of like 5 core domains across the National Community Health Worker Program in Sierra Leone. So around roles and responsibilities of community health workers, around incentives, around data, around their supervision, and around their supplies, and ask ourselves, like, what kind of data are we collecting? What can it tell us about the community health worker program, about their performance, about what their needs are, where the gaps are in each of these districts? And then what can we use that data to inform changes in policy, changes in implementation and practice, changes in the way we finance or task shift or think about the way that community health workers are taking on different roles and responsibilities. And so we were able to use a couple of different methods to ensure good data quality. I know we'll talk about that, but maybe just 2 things that I really wanted to highlight that we were excited about with good data quality was, one, we're able to really understand, are community health workers being paid on time? And if not, why? What were the gaps and barriers to that? Sometimes it's about, do they have good ways to get paid? We talk a lot about digital payment of community health workers. We also know that I think the other thing we learned was about recruitment of community health workers. So we learned that only 32% of community health workers that were recruited were female in Sierra Leone. And actually the target is 60%. And so good data meant that we could see the gap and ask ourselves why and how do we close that? And so I think that good and reliable data is not only good for like program managers and decision makers, but it's an advocacy tool. It can help us really think about how to advocate best for our community health workers, but also for the patients and the communities that we serve. So
I think you've made a really interesting point there, because often when we think about data quality in CHW programs, we're thinking about the data that the community health workers are collecting themselves around, say, like you mentioned, Hamid, maternal and child health programs or vertical interventions. But actually, if we sort of take a step back, it's important that we collect good quality data about community health workers themselves. So I'm turning to Dickson here, but it's important that we know, how many community health workers there are, where you're working, what kind of work you're doing, so that you get paid fairly. I mean, have you ever noticed challenges with getting paid on time?
As a community health worker, you work to be paid, to survive, to pay school fees for your children and all those that depend on you. So if one is not being paid, it means you are not in living in good conditions. Otherwise, you are starving. So even if we say you have to be sent to do a certain task somewhere, when you are hungry, if you have not taken in food, your child has not gone to school, I think you can't bring that good data to the one who has sent you. Actually, that will reflect everything bad on the ground, because you are not compensated on what you are doing.
Right.
So this has been done.
No, thanks for sharing that. Sure. I think it's really important, and thanks, Mallika, for sort of raising that point. I just wanted to ask briefly, you're operating at huge scales. So in Sierra Leone, you mentioned you're working in several different districts. Hamid, you mentioned that you've collected data from over 50 million individual users. Can we just ask briefly, so in episode 3, we spoke about digital and the role of digital tools in collecting data. I wanted to ask, what tools are you using? Can you just tell us the names of those and how they work? And maybe a little bit about why you started using those. I assume that the community health workers that you both work with were collecting data from paper-based sources before, maybe?
Yeah, so as I mentioned in the introduction, that community health workers have to collect all these data in the beginning on the paper. And they have lots of format for all these. So to solve this problem, there should be an application. So the challenges on the paper 10 years before was that ASHA or E&M have to do lots of work, manual, and now they are collecting this data on the application. So their manual work is reduced, but the current problem is that they have different application for different programs. So if they are collecting the data for the immunization, they have to collect in an application, and for maternal health, they have another application. For tuberculosis, they have a different application. So what we did in this application, which we have created, we integrated all the module in a single application. so she need not to enter the data in different application. And this application which we created is not just a digital tool to collect the data. It will also help a health worker when she is entering the data in the application in decision making. So let me give an example that if she is doing the examination of a pregnant woman and she is filling the antenatal checkup data in the application, and she find the hemoglobin value is less than 7. So as soon as she will put the entry of the HB in the application, the pop-up message will appear, and she will help. The application will help health worker that you need to refer the beneficiary to the nearest primary health center, or as per the reading, the pop-up message will appear. And this is how we have multiple validation in the application. So like recently we are doing this TB active case finding survey in the community. So we are doing this on the vulnerable population, and this vulnerable population we find with the digital health survey because we are also collecting the health status of the beneficiary. So if Asha is doing active case finding in the community and she is showing continuously 10 to 15 beneficiary are normal, but they are vulnerable, so there will be a pop-up message that you are doing something wrong. You have to check that you are doing all the things right. You are asking all the question from the beneficiary. So yeah, we have all these validation in the application. We are also collecting the GPS location of the beneficiary. If she is using the application from a place, then after 15 survey, there will be a pop-up message. And after doing all these things, there will be, like, as I told, that A&M is using that application on the maternal health child nutrition session day, where she have to enter the pregnant women data and also the 0 to 5 year children data with the immunization status. So after every checkup, there will be a summary for the A&M. That summary will help A&M or Asha to take the decision on that beneficiary. Is she need to refer that beneficiary? So yeah, I can say that this is a application for the ASHA, accredited social health activist, A&M and CHA can also use that application. And not just these community health worker, the MO medical office in charge who sit on the primary health center. So if A&M is referring any beneficiary for any examination to the primary health center, as soon as she will sync the data, the MO at the primary health center can see that beneficiary data in the application, and he or she can start the examination and can fill the data in the application, and Asha will get a notification or A&M will get a notification that this particular beneficiary which I have referred for some examination is reached to the facility and MOIC has. So what we are doing with these application at different level, we are completing the loop. Otherwise, A&M will not able to track the beneficiary if she visited primary health center or not. So yeah.
That's fascinating. I really like the fact that you've mentioned closing the loop. You've touched on so many amazing points here. The fact that there's a major patchwork landscape of digital health tools, not necessarily communication between different stakeholders. And actually, we did a piece of research with collaborators at Community Health Impact Coalition where we looked at ECHIS systems and we spoke with lots of different key stakeholders. So medical officers, researchers, and they said one of the key, most important things was interoperability between these platforms and as well as closing the loop and making sure that you didn't have breakdowns in communication. I also really like that point, Hamid, where you said the digital tools almost send nudges to people to prompt them. Look, this mother might have a low hemoglobin. She needs to be seen. So I think that's a really powerful example of how digital is being used to support data quality and quality of care.
Yeah, and we, as Dickson mentioned, that ASHA is based on incentive only.
Right.
So I was there on the field and I was talking with her, and she mentioned that on an average, ASHA get 5,000 INR monthly, and it is less than what a daily wager get monthly. So it's very painful that ASHA is based on incentive. There should be some basic amount she should get monthly on the time. The same situation we are facing in India also. Sometimes they get incentive after 3 months. So yeah, wow. This is the situation in India also.
And do you think the data that's being collected could be used to advocate for fairer pay for the ASHAs?
Yeah, it should be. This is why we are collecting this data. But as we are mentioning this data quality, so what I believe we have applied all these validation in the application. We are collecting GPS, we have pop-up message for the ANMs, we have summaries. So all these is helping to make the quality of data good. But what I believe, what I experience on the field is that it's people, means that it's ASHA, ANM, or the health official and the policies which make the data quality good. So yeah, I think it's, as my experience, that we have lots of validation. We can create the digital tool as we can. But if ASHA or ANM is not understanding the seriousness of that data, that how the data will be used, so I don't think we can make the quality of data good with the digital health application.
Right.
I'm saying this, even we are creating this digital health application, but what I have experience on the field, I'm sharing that on.
I'd like for us now to hear from Renata and Anastasia about how digital technologies have helped improve the quality of the data that they have collected.
Data inconsistencies are flagged immediately. If I enter incorrect information, the app detects the error right away. So, I believe that digital tools have optimized our work significantly.
How many pregnancies do I have in my community? So it just directs me. If this if this mother is almost to deliver, it just comes and tell me, go and visit who and such and such a household. This mother is almost to deliver. Then I go, I give her health talk on birth, individual birth plan, on delivery, the health delivery to go for facility to prepare.
Mallika, I don't know if you've got any examples from Last Mile Health about, how you're leveraging digital and what you're doing to enhance data quality.
Yeah, I have two, and I feel like there's a lot to learn from just building integrated information systems, especially with digital, because I think a lot of countries and governments are in the transition sometimes between paper to digital. Some are fully paper, going fully digital, some are on that path. And that journey can be really challenging because sometimes you're using both systems at once. And so sometimes CHWs are reporting on paper, simultaneously they're reporting on digital at the same time as a safety net. But then actually you ask yourselves, what kind of data quality issues are you going to have as we fully transition from one system to another? I think there are two examples, and Dickson, I'm excited to chat a little bit more because the first thing that came to mind, Hamid, as you were talking, was about like the power of an integrated information system and using digital tools. So I was just in Malawi last week, working with our team, and at Last Mile Health, we are partnering with the University of Malawi and the Ministry of Health on the design of the Integrated Community Health Information System, which we call ICIS. It is a fully owned system by the government. They have really demonstrated extraordinary leadership around moving from a paper-based system to a digital system. And I think, Hamid, you were speaking a lot about the fragmentation within primary healthcare services. And I think in Malawi, we've seen that over the decades where health surveillance assistants, which are the community health workforce, HSAs, have often delivered services in a very fragmented way. So you'll have a health surveillance assistant who will be delivering HIV services. They'll also be asked to deliver malaria services and reproductive health services, but all incentivized by different entities and just on that singular service. So I think the beauty of the integrated community health information system, which is digital, is that it integrates all the services into one platform. And so no child should have to only receive a visit about their vaccinations. They should, if they have a fever, they should also be assessed for their fever and be screened for malaria. So I think that the power of a digital information system is that it brings all of the services together under one platform, and it's delivered by a community health worker. And so ICIS, or the Integrated Community Health Information System, is so powerful because it is delivering services at the point of care and is a clinical decision-making tool. And we see that in Malawi, where I was just in a community with a health surveillance assistant, and we had just visited a mother who was 3 days postpartum. So she had come home from the health facility. She had her newborn baby. And it was amazing to see the health surveillance assistant come and first assess the mother for danger signs. Did she have bleeding? Was there any discharge? Did she have any kind of like fever, any other kind of pain or within the body? Done all of that assessment. And then just a couple minutes later, she was able to assess the newborn, look at the newborn's temperature, take their weight, assess if they had any danger signs. And that all happened in one visit by the health surveillance assistant. And all of that was documented and tracked in ICIS, the information system. All of that data is collected and it kind of flows up the chain. And so I think there's the power of digital tools if health surveillance assistants, community health workers are trained well to use them. If we create demand for that data, first from the community health worker, but then by other managers and leaders within the health system, and then we kind of like use that data for some of the decision making that we were talking about. Are services being provided the way they are? Are we able to see where there are gaps in the system? And then how do we like use that data to think about how we kind of finance these programs appropriately?
We're now going to talk about the importance of digital literacy training and how this can improve the quality of data that is collected. But before we do that, let's hear directly from community health worker colleagues in Brazil about their experiences with this and how it can help improve data quality.
But besides training, we need something called time. When the tablets and digital systems arrived in our clinics, we had a huge backlog of data to enter into the system. On top of that, we had our usual work, going into the field, registering families, returning to the clinic, entering data, and making visits. It was all very rushed. Many data entries were lost. Many records were incomplete. And then we had to go back and redo them. The more training, the better. When we received the tablets, we had training on how to use them. At first, I am not from the digital era, so I struggled with some difficulties. But we received support. Whenever something went wrong, we would go to the IT department to fix any issues. And we had colleagues who knew more about it, who helped teach those who knew less. And with time, we got the hang of it.
One of the things that would make the digital tool that the community health workers are using more efficient and improve data quality would be things like, I assume, training and supervision. Can you tell us a little bit about what you're doing at Khushi Baby or Last Mile Health to help ensure that training and supervision of community health workers optimizes data quality?
Yeah, so I am working there as an implementation lead, and it's my responsibility to train all the health workers. Okay. And the number of health workers in Rajasthan itself is 75,000. So it's a very, very big challenge to train all the health workers.
Yeah, so you're not under any pressure at all.
Yeah, and it's, as I told you, that this application have different modules. So we cannot train all the health worker in one go in all the module. That will be too much for them. So we have to launch the application in the phased manner, and we have to train the ASHA worker on one module, and then after some time we launch the different module. But what we we follow this cascade manner. We did a state orientation with the district level health official, and we identified 2 persons from each and every district. And then same thing we are doing at the district level. And then they are identifying 2 persons at the block level. And then same thing is happening at the sector level. Sector is primary health center. And we are identifying 2 persons each on every primary health center. Those persons are responsible to train the ASHA or ENM on the application itself. But yeah, it's a very, very big challenge to train the health worker, because what we seen on the field is that there are some, if you want to train them virtually on a call, so there are some time that they face network issues, and we cannot train 75,000 health worker in person. We don't need have that big team. So what I observe and what I experience, that it's the government who can train the health worker, and they should take the responsibility to train them. It's not the development partners. I don't think that they can train all the health worker, like if the number is so high. Yeah, but when we start this, the challenges was very different. But so if the ANM or ASHA is young and they are a smartphone user, they can use the application easily, because there is nothing new in the application. They are collecting all these information on the paper itself, so they know all the indicator. But the thing is that we have to train them on the smartphone. So this is the thing which, yeah.
Yeah, no, it's really interesting. And I think what struck me there is when we're thinking about data quality and ensuring that data quality is maintained, there are so many different stakeholders here. So we're not just talking about training the community health workers, but you've obviously involved government level officials, people at the health facilities. So I think I'd love to talk more a little bit later on about how we do this well at scale, and also thinking about the kind of funding implications of this. And I know you've said that it's really essential that government are involved. And I know Last Mile Health do a lot of these things, but Mallika, I don't know if you want to build on that, or if you've got any thoughts on what you're doing at Last Mile Health.
Yeah, I think data quality also has a lot to do with, like, I think, Hamid, you talked about the transition, like people are used to paper-based systems. I think they've been here for decades. And so I think we all agree that there's a lot of value and a lot of power in shifting to digital systems, but we're working with learners who are coming from lots of different backgrounds. Particularly, community health workers are adults, and their digital literacy can be very varied. You might have older community health workers who have just a very different fluency with digital tools. Even looking this close at a tool, requires that's still a big shift. And we all probably come from different backgrounds and comfort of using digital tools. And then you have younger community health workers who probably have been using smartphones since the day they were born. And so I think just recognizing that like digital literacy can be really diverse, even in this workforce, is really quite important. And one of the things that we do with the ministries of health that we work with across our 4 countries of Ethiopia, Liberia, Sierra Leone, and Malawi is really assess digital literacy. So even before you train a community health worker on the said tool, how to collect data, how to enter data, how to use it for decision making, we need to assess like what is a community health worker's actual digital literacy. And so we have worked to kind of build modules at the onset of any training that is even like, how do you put on your phone? How do you navigate on your phone? How do you charge it? How do you take care of it? And then do a lot of assessment on kind of the basic learning that comes with that. Because again, if we like kind of bring this back to data quality itself, if somebody can't use a phone properly, if they don't know how to enter the data, if they're not supported and coached to do that, the data you're fundamentally going to get is likely incorrect, it's unreliable. And then the kind of cascade or the domino effect of all of that is that you can't use that data to make good decisions. You can't use that to do advocacy. You can't make financial decisions. So I think for us, like digital literacy is a big part of this. And I think you can even talk about some of the differences between, males and females, younger and older. I mean, you could kind of stratify this in a number of different ways, but I think that piece is key. And then I think it's also about not just focusing on the community health workers, but all of the other people who are within the system. So who's the manager of the community health worker? Yes. How do they know how to coach and train and mentor their team on using it? Who are the health managers at the district or the subnational level? Who are those at the national level who are coming out to do supervision? It's like you have to kind of support every single user in the chain in order to understand how to use a digital tool in order to demand and create demand for good data, but then also to assess the data quality, which I'm hoping we'll go into is kind of like what are those strategies for ensuring data quality? But I do think it comes down to like, do you know how to use the tool?
Right.
Do you know how to use a phone? What's your comfort? Yeah. And then I think that will have an effect from there.
Yeah. So we need to get like those basic underpinnings right first. Yeah. I mean, you said you want to know like strategies for sort of assessing data quality. Mm-hmm. I'd love to ask you both, how do you do this? And something that I'm always really interested in is how do you do this at scale when, we're talking about, supervising 75,000. What strategies do you put in place to ensure the quality of data?
So in Khushi Baby, what we have created, we created these automated data quality checks.
Okay.
And we also have validation, as I told.
Yeah.
So with the automated data quality checks, what we are doing, that if the ANMs is using application on the maternal child health nutrition day, and there was like 10 pregnant women, and she is filling the blood pressure value 120 and 80 for every pregnant woman, that is not possible. So what we are doing with the automated data quality checks, we are flagging all these data. And on the basis of that, we are giving them feedback. So what we created in the beginning, we divided all the health workers into 3 groups: average, poor, and smart. And we are giving them automated voice reminder that on that day you did that MCHN session and you have put all the values correctly, but I think you have put something wrong in the hemoglobin. Mm-hmm. Can you please check that? So she, with that automated voice reminder, she was thinking that someone is looking in my data. And what we have seen with the time, that the poor health worker went to the average group and then average moved for the smarter. So these are, like, we have created more than 40 automated data quality checks. And we are also doing this, as I mentioned, that we are collecting GPS. So if ASHA worker or ANM doing the survey from a location, we are checking that she is not moving to the village, she is not going door to door. So on the basis of that, we are also giving feedback to the health worker. And with this, we also have a very good dashboard where the health official can see all the data and they can take action from that dashboard. They can see all the data on the map. So like if a health worker is collecting data and the health official can see that data on the map, and there are some beneficiaries who are prone to some diseases, or there are some beneficiaries who are diabetic, that they can see on the map that this is the area where I should take action. So this is how we are checking the data quality.
Yeah, I like that example because I think it goes back to like, what can you build in terms of data quality at the point of care? I think that a lot of data quality and data quality assurance actually happens like after the fact, after you go home. And sometimes to go fix that or to find how to clean it or to go verify could be almost like a more resource and time intensive process. And so I think the potential to really build in some of that data quality check, even as the community health worker is entering data, already reduces error. It's already ensuring a lot of that data quality, which I think is exciting and it sounds like a lot of what the potential for digital tools are.
We just heard from Hamid about inaccurate data entry and the challenges that this presents with data quality. But let's hear from Bernard about his experiences with this, what he's going to term cooking data.
It actually happened so much times. You'd find a community health worker sitting under the tree. Sometimes we call it under the tree recording. Mm-hmm. Some of them would, because when the month was approaching, when we were going for our monthly meetings, you'd find a community health worker sit somewhere to cook the data and maybe just to ensure that by the time the report is required, the report is ready. Mm-hmm. But then currently, I would say that it's not as much as it should be to be. Mm-hmm. Currently, most data that we get are actually real time. Mm-hmm. Because you go to a household, you have your phone. That phone is capturing even the location. Mm. It is capturing the time. It is giving every detail that is required of you.
And do you ever get concerned that, this is fantastic in terms of improving data quality, but I guess are there any concerns that this could be used as a punitive tool or like punishment? And, community health workers rely on ensuring that the data obviously that collected is accurate. But also from the household perspective, do you ever get pushback or concerns around this?
Yeah, actually what I have seen on the field is that if the health worker is reporting good data, like for example, let me give you an example that she is reporting that in her village, there are some pregnant women which is in high risk. So what is happening when this health manager doing their review meeting? So every month, there is a review meeting of the ASHAs at primary health center and then ANM at the block level and with the medical office in charge at the district level. So what is happening in those meetings is that if there are some pregnant women in a village in the high-risk group, they are just scolding the ASHA worker or ANM that why these pregnant women in the high-risk group. And same thing is happening with the ANM at the block level. And same with the medical office in charge. They are in the meeting with the block chief medical officer. Now block chief medical officer is scolding medical office in charge. And same thing is happening at the state level. State level official is scolding district level officials that why these beneficiaries in the high risk group. And instead of that, what should be happening as per me, that we should praise ASHA worker. We should appreciate ASHA worker that she has identified high risk women or high risk children, so that we can take action, we can examine that, we can start treatment of them. So with the digital tool, we also have to, so we are talking about the community health worker, digital tool, but we are not talking about the health officials or health manager, how we will change their mind, how they can use this digital platform and how they can take action properly. So I think we also have to work with the health manager or health official that they should use the data and they should take the responsibility and they should change their mind. Yeah, it's not just to achieve the target. It's about to make some actionable thing on the field or to make changes on the field. Yeah.
Sounds like we're really talking about creating a culture for data use. And
Yes.
so how do we create not just demand at the community level for good data, but actually how do we incentivize and support data use across multiple levels, I think, of the system. And I think the example I was sharing from Sierra Leone, where we partnered with the Ministry of Health to collect like implementation data across 16 districts. I think a lot of the work Khushi Baby does and what I'm hearing is around the data that the CHW is collecting and entering. I think the work in Sierra Leone we did was really around collecting data around the system. And so I think, James, you talked a little bit about this before, which is like, it's not just about the data the community health worker collects, it's about other types of data you can collect around the performance and the overall kind of implementation of the program and how you use that. And I think what we found that was really useful was how do you engage different stakeholders at every part of that process. So at the onset, when you're designing data collection tools, so for us, when we were designing our research with the Ministry of Health, it was engaging the ministry at multiple levels. And even in the data collection tools, what are the key questions we're asking around skills, supply, supervision, salaries, data systems, all of that? How do we ask the right questions? How do we engage the ministry? And then how do we involve the district, the national level stakeholders? How do we involve community health workers in that? And so I think you made that point a little bit earlier, which is around designing with your users in mind. And then if you can do that from the onset, I think a lot of that then creates this overall culture of not really just debating, is the data right or wrong? Is it useful or not? It's really like, what are we going to do with the data? How are we going to use that? How can we advocate at multiple levels, not only for patients and communities and the health worker, but then also for actual resourcing for the program or around like policies and strategies. And so I think it's also keeping in mind different, I think, interests and incentives of different people within the health system overall.
I think, yeah, these are really excellent points and about like stepping back and seeing the kind of systems picture. And also thinking about, Hamid, as you mentioned, this societal shift in terms of how data and data quality is viewed.
One question for you, Mallika. You gave an example of Malawi doing better in IKIS, but at a certain point in other districts, this issue of IKIS has not been there. I know as last mile, you have got your own areas of work. Maybe, I don't know how many districts you are working in Malawi. So what can be done, or how best can it be done so that each and every community health worker in Malawi and across the world, being in India, can be accessing these digital tools for the data to be collected digitally and to have that data quality? What can be done? Yes.
It's a good question. So I think in Malawi, around the integrated community health information system, we've partnered with the ministry in 3 districts to start to kind of essentially to kind of like test and refine IKIS. Of course, Malawi is a very big country, not as not as big as India, but but I think it's, kind of scaling or operating at any level of scale also, I think, requires us to be deliberate. So I think there's always a risk when you go to scale that you lose quality, and that includes data quality. So I think in Malawi, I'm hopeful that as we continue to refine ICIS, really understand what does meaningful use look like of a system in a particular geography or particular district, we can use those lessons to continue to scale with the ministry. I know the ministry in Malawi is very committed to scaling ICIS across the entire country. I think that's also resource dependent, ensuring that every health worker is trained not only on ICIS, which is the digital platform that enables not only data collection but point of care decision making, but also that they are trained in the actual service delivery content. So if you're training a community health worker on delivering reproductive health services, they need to know how to do those protocols. They need to know how to deliver those services. And then being able to document and use ICIS as that kind of ongoing tool is part of that. And so I think as the ministry is thinking about how to support the entire workforce, we need to be thinking about how do we do that in a way that is complete. We don't want health workers who are trained, what we can call it like a puzzle piece or in patchwork. We want to ensure that each health surveillance assistant is trained at full. That includes learning how to use ICIS as the kind of ongoing mentorship tool that will support their work. But I think it's also about how do you build a coalition of partners and of actors within the country to support the ministry's vision. And so, of course, Last Mile Health is one organization, but we are not the only ones in Malawi. I think we see our work as, one piece of a bigger puzzle with many other partners, many who are part of the Community Health Impact Coalition, but also part of the ministry's ecosystem on wanting to create, a system that can support, those community health workers at large. So,
no, that's fantastic.
Yeah.
So can I ask you one question? So how is your experience with the health manager or health official at block or district levels? Mm-hmm. Are they interested to using all these digital tools? Or because ministry is helping you, or because it's the initiative of ministry, you are collaborating with the ministry, that is why they are just using this tool because of the ministry pressure?
I think that Dickson, I'll be curious about your experience too. I think that district managers, district leaders are really excited about digital tools. I think, we talked about the community health worker. Probably in any geography, there's a lot of demand for community health workers in terms of providing services. I think even more so in our kind of current climate, I think we also see that even more tasks are being demanded of community health workers. And so I think if you kind of layer that up to the primary healthcare level, you see a huge demand on nurses, on midwives, on district health managers to have to kind of bundle a set of services. And so I think the opportunity and potential of digital tools, of integrated data together on one platform is something that is really excited to district managers. But I think it comes back to what can they do with the data? How do we create like a system and a culture of using that in a way that can not only contribute to making their roles easier, but also to improve the way that they do supervision, the way they coach community health workers. But I think you had already kind of spoke about this even with Asha, is that even with supervisors and managers, creating a system where you review the data on a periodic or ongoing basis is really important.
I think that's really interesting, actually, what's come out there. It's not just about training the community health workers in the importance of data quality or use of data. Mm-hmm. It's about the whole ecosystem and everyone who's involved.
And we have discussed that one motivation for the community health worker is the incentive, because they are getting the incentive, they can use the digital platform. But what is the motivation for the health official? They are not getting any incentive, any extra incentive. So why they will use this digital platform?
What do you think, Dickson?
It's fun. Actually, if we talk of these managers, honestly, they have got a lot of advantages. Maybe if we compare them with the community health worker who is deep down in the community, this one is working as a volunteer at a certain point. Yes, in Malawi, some of us are employed. But if you go and check what this health worker is getting compared to what the manager is getting, it's quite different. So yes, they need to be to be compensated or given an incentive, but the key point person is this one, a community health worker. Because if you don't compensate this person, the whole thing that we are talking about here would not work. Community health worker would not bring quality data that we want. Because I know those managers are there just to analyze what has been collected deep down there. So the first thing is to compensate these people who are doing the good job. And also, they're the ones who are much connected with the community. I tell you, this senior person, if he can go or she can go in the community to perform any task, she or he cannot be accepted because the community does not know this person. But they have a very, very good link with the community health workers. They are able to interact on various issues. They are free to share their issues to these CHWs, and yeah, they are like they are partners in everything. So yeah, your concern is very true. But to me, I suggest we should look actually critically on the community health worker who is doing the great job deep down on the community.
Why actually I'm asking this question, what I have seen in India with these health officials. So these community health workers is now starting using smartphones, and most of them now have their smartphone with them and they are collecting this data. But whenever I am visiting any health official at the district level or block level, I did not find any desktop in their chamber. So they supposed to have a desktop to monitor all these data. So what they are doing, they have their assistants. If they want to monitor any data, they are asking their assistant to please give me that print, or they are monitoring data on the paper. So what is the use of the digital tool if they are not using that dashboard which is created for them?
So I guess it's about encouraging buy-in, but that's a really tough question. And I don't know if, and again, I think this is where it's really hard at scale. So even when you were saying, we have 75,000 ASHAs to train, we don't do any of the training necessarily in person. Do you ever have concerns around what happens if there are 2 or 3 ASHAs working in an area with vulnerable patients who really do struggle with using the smartphones or the digital tools? How do you then identify those at the scale of 75,000 and make sure that they are getting the support they need? I don't know if you've got any practical strategies around this.
No, that can be doable from the dashboard, but what I have seen on the field, they don't care all these things. They just care about the target. They just want to achieve the target. If the target is achieved, their job is done.
Right.
So I don't think it may be changed with the time, as we are saying that we are doing lots of things with the community health worker, but not much with the health official. So what I think that we should have a session, monthly session or a quarterly session with the health official at the state level or at the district level, and tell them how important it is to using the digital tool and how the digital tool can make their job easy. So we should have all these sessions with these health officials, then only it can change their mind.
Yeah. So I guess it's about not operating in silos and trying to get buy-in from everyone across the whole ecosystem. I've just got one more question for you guys. It's quite a big question, but I was wondering, obviously there's a lot of talk around AI at the moment. And what are your thoughts on how AI might improve data quality? I don't know if you've got any examples, Hamid, as well.
I can give you an example. AI can improve the data quality. So recently what we created Asha Saheli. It's a WhatsApp chat bot which Asha can use on the WhatsApp if she have any doubt related to any program, not just use the digital health application. So recently we launched this active case finding on the field, and we are giving them training on the digital tool, and most of the time we are focusing on the program, why the screening is important and how she should do the screening, what are the things which she should keep in the mind. So all these questions she can use from that Asha Saheli. So I think AI can help them to build the knowledge or if they have, so like what is happening on the field, Asha is on the village and there is no network and there is no ANM or MOIC with them. And if she want to ask any question, if she has any doubt, she can use that AI bot at that time. So I think this is how AI can help the ASHA or the community health worker. And as I mentioned that we have these lots of validation in the application. So AI can also help in making these validation, or at the time of data entry, at Mallika mentioned that we have to check the data quality at the time of entry itself. So yeah, AI can help that decision making to the health worker or at the time of data entry.
Yeah, I agree. I think AI is really exciting. It obviously comes with needing to be cautious around things like data use, data sharing, data permission, especially as you do have sensitive patient information. I think assuming those things can be factored in and controlled for. I think the potential for AI to help with efficiency, with time, with accurate decision making, with the ability to take clinical protocols and routinize them in a way that is accessible to health workers is really exciting. I think we're exploring work around how to take clinical protocols and allow different health workers to be able to call in and be able to get targeted support for specific cases where they might have questions. We're exploring the ability of AI to optimize the translation of work, of clinical protocols into more local languages quickly, because that can be a very time-intensive process. I imagine in a place like India, where there are different languages, multiple different languages spoken in different states, the ability to have to contextualize and tailor work to different health workers' needs can be something AI could bring huge potential for. And I think I really go back to the fact that community health workers are so depended on. They provide so many critical services at the point of care at the community level that often they're overburdened with tasks. They're over-relied on. The community relies on them. The health facility relies on them. We talk about it even at the national level. People say, who's the first face that you see when there's a disease outbreak? It's the community health worker, right? And so if you think about the number of tasks that are being put on a community health worker, they are carrying so much of that load day to day. How do we make that easier? How do we leverage digital tools? How do we leverage the power of AI in a way that can help reduce the work they do day to day in a way that helps them do their jobs better? And I think if we can think about it in that way and design with them, and again, kind of bring in that digital literacy piece, I think there's a lot that can be unlocked as part of that. But I think we're only scratching the surface on AI, because I think we're still only scratching the surface on how to ensure community health workers can use digital tools accurately and are really well equipped to. So I think we have to proceed with caution, optimistic caution, but in a way that really sets up the community health worker to do that successfully.
That's fantastic.
Yeah, I agree. So the ultimate goal to create this digital tool for the community health worker is to make their work easy. And we started doing this, I think, 5 or 7 years before. And now with the time being, we created lots of application. There are lots of validation. She also have to use the WhatsApp and lots of application for a different program. And now we are talking about the AI. I agree that AI can help a health worker on the last mile, but these are lots of things she have to use. And the main work of ANM is to do the clinical thing. She have to do the examination and make aware beneficiary about the health issues. But their most of time is going to use this digital health application and to capture the data. In their mind, that what is happening is that they just need to collect the data from the field, and they have to give the data to the health officials, and health official will use that data. I think this is not the job of community health worker. The main job of community health worker is to make people aware, do the examination on the time, take action. If they find any beneficiary in the high risk, they should refer all these things. But their time is going to use all these tools. Mm-hmm. And we have promised that it will reduce the work. But what is happening that right now in India, in Rajasthan, there are almost more than 15 applications for the community health worker. For the immunization, there is a different application. For antenatal checkup, there is a different application. For TB, for tuberculosis, for NCD, for death module, for creating Abha ID. So there are lots of application, and she have to mention all the basic indicator like my name, gender in all the applications. So it is not reducing the work of community health worker. It's actually increasing.
I would also say in a future state, I think leveraging AI in a way to assure data quality is something I'm hopeful for. So how can AI help like review and optimize and routinize data in a way that then that data can maybe be translated or used and packaged in a way that can be useful for different sets of stakeholders? So how can we generate good data quality that then the data can be used at the community level to really review? I think in India, there's a really good culture and practice of sharing data back with the community so that a community can understand different like incidence and prevalence of disease. So then in the same way, how can we leverage that type of technology to create data that is useful for especially district and program managers or at a national level with kind of key stakeholders?
And I think Khushi Baby have partnered with Google AI for social good to create scores for health officials.
Yes.
Is that right?
So we work with the Google AI and so there are multiple applications as I mentioned, and what we are doing now, we are creating an integrated dashboard for the health official where we are taking the data from different portals, and on the basis of that we are creating a score and a composite score, and then we are giving a rank to the block or district, and they can see all the state level health official can see all the district data on the dashboard, and they can see the rank, and they can also take the action from the dashboard that you are not doing a good thing in the program, so they can issue a letter from the dashboard. So this is how they can monitor all the data in a single platform, that is integrated dashboard.
So there is a potential here as well for partnerships between governments, NGOs, and also private companies like Google for social good here potentially.
Yeah, as I mentioned that we created this Asha Saheli, the chatbot for the community health worker with the Microsoft.
Okay.
What has been the most interesting thing that has been discussed today in this conversation?
A lot. I think the point that really is stuck with me is around the considering the ecosystem when we talk about data. So I think there's a lot of great examples. I've learned a lot around the work Khushi Baby is doing, but around how we think about the role of the community health worker in data quality. But I think what stands out to me is also that the community health worker is one piece of a bigger puzzle. And I think rightfully so, we place a lot of importance and prioritization on the community health worker, but there's also a lot of responsibility of the actors within the ecosystem to be generating and identifying and generating data that is going to ultimately support the community health worker to do their job. And so for me, I think the responsibility lies in many of us who are working, whether we're implementing and supporting community health workers directly, if we are designing programs and policies with government or subnational actors, that ultimately we need to think about kind of what are the multiple stages and level of data that can be used to build a resilient community health worker program. And to me, it's about empowering and supporting the community health worker to collect and generate the best data and evidence they can. But it's also about, our role as a not like an NGO, our role as supporting and partnering with government, our role as supporting patients and communities to ultimately think about how data can be used across different actors within the system. And then to assure quality data means to be able to build and deliver the best services possible to that young baby or that mother. And so I think just remembering coming back to why we do this work and what's important, it's about can we make sure that mother and that baby are supported at the time they need it most? And that all trickles back to, I think, like the collective responsibility we all have, not only to like design good programs and collect good data, but to use that for a good purpose.
Yeah, I think I agree what Mallika said, that we are discussing lots around the community health worker, but we should also focus, what we have discussed today is that we also should focus on the health officials or the health manager. We should involve them. We are discussing how the AI can help the community health worker, but we should also discuss how the AI can help the health officials. So we should, so this is the thing which I think it's the main thing for today's discussion, that we should involve health officials, health manager, when we are discussing things with the community health worker.
What about yourself, Dickson? What's come out of the conversation for you today?
Yeah, I think one thing that has been mentioned a lot is what was just said by Hamida about involving the senior managers on the issues of data. Yeah, at a certain point, it's just very true because if these managers are not involved in data collection, sometimes they might miss what has been collected down on the ground. So it's very, very important to have the whole chain complete, so that whatsoever has been collected is also analyzed as is required. So that's a very, very big, good, important that has been made point. Right. Yes, sure.
It's fantastic. And thank you so much to both of you for spending time with us today. There's been some amazing things that have come out of this conversation, especially around data quality. And it's definitely given me, and I'm sure Dickson as well, renewed food for thought in terms of what do we mean by data quality? Who is this data important to, and how are we involving community health workers in improving data quality and also the use of digital? But also, I guess, thinking about how do we not just think of data quality as bits of data being input onto a smartphone, but also in terms of closing the loop and the use of that data, and also obviously the key stakeholders involved in this. So really excellent discussion with you guys. And again, just a huge thanks to the great work that's been done at Khushi Baby and also Last Mile Health.
Thanks.
Thank you.
We hope that you enjoyed this episode. If you did, please consider sharing it with a friend or a colleague and leave us a review wherever you get your podcasts. It really helps others to find the show. And don't forget, episode 5 is now available.